All right. Hello, everyone, and thanks for coming in and tuning in to today's grand rounds for the Australasian Metabolic Health Society. Today, we've got a very special presenter all the way from the US. Professor David Diamond is a member of the low carb community and has been for many years now, and is a well-respected voice, especially when it comes to cholesterol. He has over 150 publications, reviews, and book chapters, and has actually co-authored one of the best papers on cholesterol I've read a few years ago, along with Dr. Ben Bickman and our very own Dr. Paul Mason. He received his PhD in biology in 1985 from the University of California and has a specialization in neuroscience. And he recently retired as a career scientist in the Department of Veteran Affairs following 30 years of service, and is currently a professor in the Department of Psychology, Cognitive, Neural, and Social Science Division at the University of South Florida. And his current research interests include the study of stress, brain, and memory, and mechanisms underlying cardiovascular disease, which we will be focusing on today. So with that said, I'd like to hand over to David to start his presentation. Oh, David, I'm just going to unmute you. Oh, you might have to unmute yourself, actually.
All right. Can you hear me now?
Yep, perfect.
Fantastic. All right. So thanks again, Alex, for introducing me. Thanks to Laureen for inviting me to give this grand rounds. And again, thanks to the AMHS for inviting me to speak today, talking about whether or not one should be concerned about high LDL cholesterol when one is on a low carb diet. So let's begin with my disclosure. As Alex said, I received a PhD in biology 40 years ago. And in the past 4 decades, I've received millions of dollars of funding from these federal organizations, as well as drug companies, for my research, primarily on PTSD and Alzheimer's disease. But I'll not be speaking about that research today. What I am going to be talking about is cholesterol and heart disease. And for me, this was and is personal. 26 years ago, I was diagnosed with what's referred to as familial combined hypercholesterolemia. I had astronomically high triglycerides and extremely high cholesterol. And I've spoken about this many times in the last 15 years. I addressed my high triglycerides by going on a low carb diet. Now the question is, what do I do about my high LDL? And as it has here, my doctor has urged me almost pretty much on an annual basis that I should go on statins, to which I have refused. So I still have very high cholesterol. My LDL is 200, and I have not decided to take any medication for it. So I'll share with you how I've come to that decision. So indeed, high LDL cholesterol is obviously a great concern, and particularly it's a great concern for people on the low carb diet. So here is a paper on the whole food ketogenic diet talking about, well, the problem was these people had increased LDL. So talking about potential harms of this high LDL. And here you have quite a few scholars who wrote about what's referred to as the lean mass hyperresponders. And these are people who on a ketogenic diet develop astronomically high LDL. And they state rather unequivocally that people with high LDL, that is the LMHRs, as well as anyone with high LDL, should lower their lipids to reduce their risk of cardiovascular disease. So this clearly is something that you're finding, that you lower your triglycerides, you improve all of your biomarkers, you have increased LDL, and so you're recommended often then you should go on a statin. And so when we look at the conventional view, that this is in textbooks and in publications, that we see that where the arrow is, that LDL as a concentration dependent factor intrudes into the artery wall, where it becomes oxidized, engulfed by macrophages, that becomes a foam cell, and ultimately develops into a plaque. When you get LDL increased over the decades, then you have increased plaque, which ultimately chokes off arteries and brings about early coronary events and cardiovascular death, as well as all-cause mortality. So this is the conventional approach. And when you see this emphasized actually in publications, but here in the Journal of the American Heart Association, what you see is that people with high cholesterol, without reducing it with medication, result in a relatively early premature cardiovascular event or death. So people with very high LDL, these are people with familial hypercholesterolemia who are born with high cholesterol, really can't expect to live much beyond 40 to 50 years. The idea is that high LDL is therefore producing plaque, choking off the arteries and causing premature death. Well, the theme of my presentation really follows this statement by T.H. Huxley 150 years ago. Great tragedy of science, a slaying of a beautiful hypothesis by an ugly fact. So the question is, are there ugly facts that would potentially show that this view of LDL is not correct? And that really is the theme of my talk. So we start off with a problem. You normally hear about coronary heart disease, but what about cerebrovascular disease? I mean, if LDL being high just simply intrudes into the artery and blood vessel wall, well, then you should see high incidence of stroke. And yet here, in a very nice study in which you verify people with familial hypercholesterolemia, or FH, you do not see an increased incidence of cerebrovascular disease or ischemic stroke. This is clearly inconsistent with the idea that high LDL from birth is resulting in clogged arteries. But let's look more broadly. Let's look at lifespan. Here's work by John Castelline, a strong statin advocate, in which they conducted a study, a genealogical study, looking at people back into the 19th century that can be traced that had FH. And their conclusion was that people in the 19th and into the 20th century with high lifetime LDL levels from birth had a normal lifespan, reached old age. And in fact, they conclude that hypercholesterolemia conferred a survival advantage. They reviewed the literature, actually, to show that this was not an anomaly, that, in fact, there are other studies that showed that people with hypercholesterolemia had a normal lifespan. And they lamented that the findings have been largely ignored. Let's look at that study that they're referring to by Harlan et al. And here's the paper published in 1966, an extremely large number of people with very high LDL levels. Presumably they had FH. This paper was published in 1966. And the conclusion of these authors was there's no evidence that having high lifetime LDL shortens a lifetime, either men or women. And in fact, people with extremely high LDL, we're talking 200 to 300, lived into the 7th or 8th decade. Lark, a more contemporary approach.
But now I'm president.
I can hear someone. There's some feedback, perhaps. Someone may want to mute your mic. So here's a more contemporary study looking at people with FH, verified FH, almost 5,000 people. And what you're looking at is the rate of death of people with FH, specifically for each age decades. So if you're looking at the first 4 decades of life, again, these are looking at, in this study, they looked at people from birth all the way into their 90s. So in the first 4 decades of life, what you find is a very slight but non-significant increase in mortality. So the 1.0 is the rate of death for the general population. And so what we're looking at with the blue bars is a very slight, non-significant increase in mortality. And in fact, a subset of people with FH do actually die prematurely. And I'll get to why that happens later. But now let's look as they age. As these FH people get older, we find something very odd. They're actually dying at a lower rate. So this is age-specific rate of death. They're dying at a lower rate than the general population. And in fact, it's beginning with 60 years of age. For people in their 70s, with people with FH, they're dying at a significantly lower rate than the general population in their 70s. So you see this 40% reduction in all-cause mortality. And let's look more closely at this group. So this is in people in their 70s that are dying at a 40% lower rate than the general population. Let's look at specifically what are they dying of, cause-specific mortality. And you see their cardiovascular death rate is not significantly different from the general population. That's why it's here at 1.0. But their rate of death from cancer is dramatically reduced to 50%, and all other causes of death are dramatically reduced to about 30% of the general population. This is something that people are not taught in medical school. It's not something widely known, but here it is, this group, which by the way is strong statin advocates, shows that frankly, it's incredibly healthy to be in your 70s and have extremely high cholesterol. And again, these people have spent most of their lives with high LDL, and most of these people are not taking statins. And the dramatic improvement in mortality in cancer and all other causes is clearly not related to any medication a subset of these people are taking. So is it only FH people that actually have an advantage as they're older? Well, the answer is no. I've had the great pleasure to work with some outstanding clinical scientists led by Ufi Ravenskov and so many others here. And we reviewed the literature on the elderly and cholesterol levels, and the elderly being all people over the age of 60. And what we found was there was not a single paper that showed a higher rate of mortality in people with the highest level of LDL compared to the general population. And we conclude here that, well, if the people with the highest LDL live as long or longer than those with low LDL, well, then clearly there's something wrong with the cholesterol hypothesis. And for those who say, well, the people with the low LDL, they're frail, they have cancer. It's even if you eliminate the people who died within the first few years of starting the study, you still see that the people with the high LDL actually have greater or equal longevity to those with low LDL. So the reverse causation is really not a strong argument against this. So why is it that people with high cholesterol are so healthy? Well, it's been known for decades that cholesterol in general and LDL particularly are important components of the immune system. And it's highlighted here in one of the cut and pastes I've taken directly from these papers, is that specifically LDL protects against the lethal effects of the endotoxin, that is the lipopolysaccharide that's produced by bacteria, which is a big component of the inflammatory response to an infection. And in fact, LDL binds to the LPS and helps to mitigate against infection. So this is something that cardiologists often either ignore or are not aware of, but the LDL is an important part of the immune system. So let's see how that may play out in real life. So here what we're looking at is 30,000 people healthy. So we're not talking again reverse causation in which people have low LDL to begin with. Talking about 30,000 people healthy at the beginning of the study, and a subset of those people develop sepsis, which is an extreme autoimmune response in which the immune system, for unknown reasons, attacks our own organs and results in a high level of organ damage and mortality. And when you find is that the baseline level of LDL is now associated with increased risk for developing sepsis. So those people that had low or moderately low LDL had significantly greater incidence of sepsis compared to those people who had extremely high LDL, a level of LDL that would be considered to be a risk for developing heart disease, the fourth quadrant of LDL. So again, the LDL is important. It mitigates against infection, and it contributes to why elderly people are so healthy, those which had high LDL. And also, by the way, this was found for people who had naturally low LDL, as well as those on statins. So the two groups independently, those who used statins and had low LDL and those who had naturally low LDL, both showed significantly more sepsis than those with naturally high LDL. And in fact, the authors showed that this is not random, this is not related to frailty. This is specifically because having low LDL interferes with the ability to clear bacterial toxins from the bloodstream. But let's get back to heart disease, okay? So what we have here again is FH. These are, again, people who have high LDL from birth. And so in this study, what you have is all the people in the study are put on statins. And now you're looking at the incidence of a major coronary event. And so over the course of the 10 years, you have different groups. You have in red the group that has no coronary events. And we're going to look at the group in blue that has coronary events. 20% of them did develop coronary event. And when you look at the graph here, you see that their LDL is basically equivalent. So the LDL doesn't tell you which group is going to have the coronary event. What is so important, and what is frankly the best indicator of coronary events, is the coronary calcium. And so the group in blue, in which 20% had a coronary event, had rather high coronary calcium at about 230, whereas the group that did not have coronary events had 0. It's down there in red. And this clearly is by far the best indicator of coronary heart disease, for future coronary heart disease. And frankly, it's either been ignored, it's been dismissed. Doctors often don't want you to get that measure, I think for 2 reasons. First, there's largely no association between coronary calcium and LDL. And second, there's no drug that will reduce coronary calcium. But it is really important to see the link of coronary calcium to coronary events, which is independent of LDL. And in fact, the authors make this point that nearly half of the FH patients have no coronary calcium, which means they're at extremely low risk of developing heart disease. Okay? So there's evidence that it's not LDL. There are other factors that are so much more important than LDL in determining coronary heart disease risk. So this study actually showed a really important factor, which is fasting blood glucose. So the individuals that developed coronary events had significantly higher fasting glucose in the pre-diabetes region of about 123 milligrams per deciliter. And those that didn't have events had fasting glucose below 100. So clearly what we've got is a biomarker that's a far greater indicator of coronary events in fasting glucose compared to LDL. So we published a paper, and I had the great pleasure to publish this in BMJ, Evidence-Based Medicine, 5 years ago, with some just outstanding co-authors, including 5 cardiologists, in which we're addressing poor guidance on dietary guidance for people with FH. But the important point here is we reviewed a paper that assessed the evidence of coronary heart disease in people with FH. And you notice that the people with FH that have low insulin and low waist size in the bottom half in waist size do not have significantly more coronary artery disease than the control population. And it's not until you have people with high insulin, and especially high insulin and large waist size, that you see a dramatic incidence of coronary artery disease. So again, these are people with lifetime high LDL, but really what's crucial is being overweight and having high fasting insulin. It's associated then with coronary artery disease. So let's look also at another paper, an important study, again, on people with FH, emphasizing a lifetime of high LDL. So here we have, again, strong statin advocate John Castelline publishing an important paper in which these are people who have astronomically high total cholesterol, over 350, and LDL, about 275, and we have 2 groups, one diagnosed with coronary heart disease and one without. The one in red with heart disease, the one without in blue. And you see no significant difference in their total cholesterol or LDL for those who have versus those who don't have coronary heart disease. You do see a slight difference in HDL and slightly higher triglycerides in those with the coronary heart disease. But the really important finding from this study is here. The ones that developed coronary heart disease have a polymorphism of the prothrombin gene. And so there is a polymorphism, which is not only in the FH population, but it's in the general population. And you find that those who have this polymorphism have higher prothrombin levels, which is a critical coagulation agent. And having more prothrombin means you're more likely then to develop heart disease. And as you can see, this is independent of their LDL levels. There are just so many studies that have shown that coagulopathy, which is increased clotting factors, as well as reduced ability to break up clots, fibrinolysis, is clearly related to coronary heart disease. And I had the pleasure to work with Ufi Ravenscott, Michelle DeLorgerel, and Malcolm Kendrick, in which we reviewed this literature. And when you have studies that have looked both at LDL and clotting factors, what you find is the clotting factors are far more significantly related to coronary artery disease than is the LDL. And that's what we concluded here. Coagulopathy is the critical factor in determining the small subset of people with FH that develop heart disease. And here is just a general summary in which when you look at all these different risk factors, as you look around, you see all the risk factors for developing coronary artery disease. What you find is coagulation factors such as fibrinogen. You've got also reduced fibrinolysis, the breakup of clots related to, in the middle is a picture of clot formation as well as degradation. And it is just that subset of people with FH that have increased clotting factors or reduced fibrinolysis that are the ones that develop cardiovascular disease. Now, is cholesterol completely innocent of causing heart disease? Well, this is a bit complicated because this is why what you find is lipidologists emphasize you have to look at the particle, the LDLP or ApoB. Now, for a healthy person with low triglycerides, low blood sugar, what you find is the LDL particle, okay, is considered to be dominated by these large, buoyant LDL particles. Whereas if one has high triglycerides, high blood sugar, what you see then is a greater incidence of a production of what's referred to as the small dense LDL. It is structurally different from the large buoyant LDL, and it is highly associated with heart disease, but it's also associated then with triglycerides and higher blood sugar. So we really need to look at the structure of the LDL particle to understand how LDL could be involved in the development of heart disease. So here's a study in which you're looking at people that either have very high small dense LDL or very low small dense LDL. And those who have high small dense LDL have extremely high triglycerides, as well as a high percentage of these people are diagnosed with metabolic syndrome. Whereas those that have a low percentage of small dense LDL have a low incidence of a low amount of triglycerides, as well as a low incidence of metabolic syndrome. So it's really important to understand that the small dense LDL does not exist in isolation. It is a part of metabolic damage. And so when you've got the small dense LDL, you've also got higher blood glucose and higher triglycerides and lower HDL. And so what are the consequences then of really being metabolically unhealthy? Which one indicator is the small dense LDL. So those who have a dominance of small dense LDL have greater incidence of coronary events, as you see here, and those that have lower small dense LDL have a lower incidence of coronary events, whereas a large buoyant LDL on the right tells you nothing about the incidence of coronary events, here looking out over 10 years. And so I really want to emphasize this is where you can see an association of LDL particles with coronary events, but I want to emphasize these small dense LDL particles do not exist by themselves. They are a part of a metabolically unhealthy person. So let's also look at LDL-C. There's just too much emphasis on LDL-C in my opinion. And why is that? Well, LDL-C is just the total amount of cholesterol that's in all of the LDL particles. So it's this combination of the small dense LDL and the large buoyant LDL. And what happens when someone goes on a low-carb diet is that their small dense LDL declines and their large buoyant LDL increases, and so their overall LDL-C can increase. But you need to understand then to see that you've got a difference in the quality of the LDL particles. You've reduced the triglycerides, the blood sugar, and reduce the small dense LDL, you've increased potentially one that's either benign or even helpful, and that's the large buoyant LDL. So overall, your LDL-C can increase, but may very well be dominated by the large buoyant LDL, which at worst is benign. Let's also look at another problem with LDL-C. So LDL-C includes, typically in a standard lipid panel, lipoprotein A, or LP little a, because LP little a is virtually identical, almost identical to the LDL particle, but it's completely different in its function from LDL, and it can be a risk factor for heart disease. And so that's another problem, that LDL-C is a hybrid measure of these multiple components. And in this particular study, these authors were able to distinguish the LP little a component from the LDL components in LDL-C. And what they point out is when you eliminate the LP little a component, then LDL-C was no longer associated with cardiovascular disease. So this shows why it's frankly quite foolish to be focusing so much on LDL-C when it is really such a poor measure of the components that potentially are related to heart disease. So how about observational studies? Can we actually look at metabolically healthy and unhealthy people who have high LDL-C and look at their incidence of coronary events? So here is a very nice study where they're focusing on two really important measures, triglycerides and HDL. And so that ratio of triglyceride to HDL has been shown to be one of the best indicators of the likelihood of developing cardiovascular disease. So those with a very low ratio, triglyceride to HDL, have a low incidence of cardiovascular disease, and those with a higher ratio are more likely to develop ischemic heart disease. So what you have here on the left are the people who have, in blue, the very good ratio, less than 1.7. And in red, what you have are people who have higher ratio, clearly having more events. And you can see how it's independent of their LDL. So the ones on the left have less than 170 milligrams per deciliter, and the ones on the right have extremely high LDL-C, over 170 milligrams per deciliter. And you see that the triglyceride to HDL ratio holds. This is so much more important than looking at LDL-C. If you know the ratio of triglyceride to HDL, then you clearly have a far better assessment of the risk of developing heart disease than knowing the LDL-C, which you can see is quite useless. And the authors really have emphasized that. They're talking about people with hypercholesterolemia, which is high LDL, but having low triglycerides and high HDL, which is what you find with people on a low-carb diet, probably, I would say definitely, do not require drug treatment for their hypercholesterolemia. And this applies to individuals as well. This is a rather nice case study that I found for people with FH. This turns out to be a father, an 84-year-old father with FH. And this is from a time in which there was absolutely no control over cholesterol, published in '93. And the father, who's 84 years old, in excellent health, no cardiovascular disease, and a son who has inherited his genetic anomaly to produce FH. So the father and son have equivalent total cholesterol, a lifetime cholesterol at about 350, and LDL at over 250. So they have equivalent LDL and total cholesterol because they have the same genetic predisposition. But the father is healthy. The 50-year-old son now has coronary heart disease. So when we look at what's critical, the triglycerides and the HDL, we have an explanation for why the father is healthy and the son is not. The son has very high triglycerides. The father has low triglycerides. The son has low HDL, and the father has high HDL. Again, a sign of good health in the father and a sign of poor health, poor metabolic health in the son. And when you look at the ratio of triglyceride to HDL, you see that the father's ratio is quite good at about 2, and the son's ratio is 3 times that of the father. And the authors commented that it would appear that the son has what's referred to as phenotype B. And this is what happens typically with high blood glucose, high triglycerides, and low HDL, which is associated with coronary heart disease. Well, what about statins? Will statins help someone independent of their metabolic health if they have high LDL-C? So here's a very nice study, actually, which is a reanalysis of one of the first statin studies conducted about 30 years ago, the 4S study. And so the question they asked was, if we take the people that have extremely high LDL, so they're all in this range of 176 to 195, and we have people who are metabolically healthy and metabolically unhealthy, which are put on placebo or statin. So the people who are metabolically unhealthy, referred to as atherogenic dyslipidemia, they've got extremely high triglycerides, very low LDL for an overall ratio of 5.9. You've got people with extremely high LDL, but with low triglycerides of 89, HDL 63, so their ratio is 1.4. So you now have four groups, those on a statin and those on placebo. Now let's look at the outcome. So those who are metabolically unhealthy with atherogenic dyslipidemia, you've got LDL is very high for those on placebo, and they have a high rate of events. And now let's go back. Let's look at those who had their LDL lowered with a statin. So the LDL is lowered from 185 to 121, and there is a dramatic reduction in events. This is one of the largest effects I've ever seen with statin treatment. So you have a reduction, of absolute risk reduction from 35% to under 20% with an event as a result of statin treatment. Now let's look at the placebo group for those who are metabolically healthy. That's called isolated high LDL. You see that their LDL is equivalent, these are the placebo people, is equivalent to those who are metabolically unhealthy, and there's a dramatic and significant reduction in events. This is without any treatment. And so now we give these people a treatment, and what we find is the LDL is reduced dramatically to 112, and there's a slight but non-significant reduction in coronary events. So this is actually a very important study that tells you that it's not the LDL, because you have a significant difference in events despite an equivalent LDL. And you have a significant reduction of LDL without a significant reduction in coronary events. So this provides strong support for the indication that statins may actually help people who are metabolically unhealthy. But statins do not have a benefit for people who are metabolically healthy, low triglycerides, high HDL, but also with high LDL. So why is it statins have this effect, which appears to be independent of LDL? Well, it's been known for decades that statins have pleiotropic effects, independent of LDL. And in fact, this review very nicely states that LDL cholesterol is weakly associated with coronary events, that in fact the statins have non-lipid mechanisms, such as their anticoagulant effects. And so it's likely that these people are metabolically unhealthy. It gets back to the coagulopathy. And so by having high LDL turns out to be irrelevant, but having other factors, the high blood sugar, increased inflammation, high triglycerides, and low HDL, ultimately results in increased clotting factors being activated. And the statins potentially are now helping those people to have reduced coagulation. So you say, fine, then you might as well take a statin. At worst, it does nothing. Well, at worst, it potentially does have adverse effects, which I would emphasize have been minimized, have been disregarded. The adverse effects of statins are really very well described in the literature, and clinicians see this in their patients. So one example, which I think has really been minimized, and this is one of the best studies, is the diabetes, the diabetogenic effect of statins. This has been minimized to a great extent. But here's the best study, I would say, in which you have a large number of people. At the beginning of the study, not any of the people diagnosed with diabetes, and you see spontaneous diabetes developing in placebo group, about 6% of them, but almost twice as many 11% of these people on statins develop diabetes. So this is actually extremely well described that statins increase the susceptibility to develop diabetes. This study was done on men, and the same finding has been shown in women as well. And there are just so many studies that have documented this in the medical literature. The adverse effects of statins, such as erectile dysfunction, low testosterone, kidney disease, musculoskeletal damage, and injuries. Not only the diabetes, reduced bone quality for those chronically on statins, and tendinopathy. So the adverse effects of statins are extremely well described in the medical literature, and I would suggest they have been largely ignored. Now let's look at actually what does the American Heart Association say about statins and adverse events. So many people report this kind of brain fog when they are on a statin. And we published a paper actually showing that the statins that have access to the brain, that can get through the blood-brain barrier because they're more lipophilic, those statins are associated with more cognitive deficits. And so here is a study in which actually the patients were largely on lipophilic statins, such as Lipitor. And they're referring here to these non-serious reversible forgetfulness and cognitive impairments. And I have to tell you, if I'm on a statin or you're prescribing a statin to a patient and that patient has a cognitive deficit, I don't know how you can call that non-serious. But this is what the American Heart Association refers to as an adverse statin effect. And let's look at one of the papers that has looked at this. The first thing is these researchers found that patients on statins appear to have cognitive deficits. So you have 75-year-old men and women, all of whom have come to their doctors and reported that they have cognitive deficits. All these patients now are taken off of their statin. And what you find is, whereas previously the entire group was diagnosed with dementia, as a result of being off of the statin for about a month, the cognition improved with the discontinuation of their statins. As a group, they're no longer diagnosed with dementia. The critical manipulation now is they're all now put back and re-challenged with a statin. And once again, this group is diagnosed now with dementia. So what we really need to be cognizant of is that we have an epidemic of Alzheimer's disease, and we have a high percentage of elderly people on statins. And we have no idea if they actually have a real organic disorder or if a large number of these people who are diagnosed with Alzheimer's actually have the cognitive deficit because they're on a statin. And this is something that just as simply has not been studied sufficiently. So as we're now trying to understand, what's really going on here, how is LDL involved? What's actually causing coronary artery disease? This model clearly is insufficient. This idea that LDL has a concentration-dependent intrusion into the artery wall just simply doesn't work because people just are so healthy throughout their lives with very high LDL. Well, I think there's an important point again made by John Castelline, that there is an interaction between genetic and environmental factors. So what are those environmental factors that are so much more important than the LDL? Well, what has been largely ignored is the importance of the glycocalyx. And so this is a layer, a gel-like layer here in this electron micrograph of an artery. And here you see it close up. So this is a protective component that lines the inside of the artery wall on the endothelium. So the diagrams that just have LDL coming into the artery wall don't include the glycocalyx. Glycocalyx enables the artery wall to be so healthy, to produce nitric oxide, which keeps blood pressure low. And so under normal, healthy conditions, when you've got high, large, buoyant LDL, high HDL, low blood glucose, and low triglycerides and blood pressure, what you've got is a nice flowing artery. You have no intrusion of the LDL into the artery wall. Now you have a metabolically unhealthy person. When a person is metabolically unhealthy, you find it strips the glycocalyx away from the artery wall. You then have platelets that can adhere to the wall. You have literal damage to that artery wall, which is like a wound. And through that artery wall, now you can have calcium that can accumulate, platelets aggregate, you have increased blood pressure and the triglycerides, and you have some small dense LDL, which may very well now be able to intrude into the artery wall through a wound that is a tear in the artery wall. So it's potentially then in which you've got the small dense LDL. And small dense LDL, by the way, now is highly susceptible to be glycated. And so because it is damaged, it doesn't bind to an LDL receptor. It must be removed by macrophages. And so the small dense LDL is now intruding into the artery wall along with the calcium, then contributing then to coronary artery disease and ultimately increasing inflammation, which down the line becomes plaque development. There is one study, as I bring this to a close, that I think is so important. These investigators were actually able to measure the glycocalyx in middle-aged people. And so they're looking at the glycocalyx in healthy middle-aged people and then looking at the rate of major coronary events in the next 6 years. What you find is irrelevant in related to those who have events is hyperlipidemia. So LDL is irrelevant. Those who develop diabetes and those with hypertension have significantly increased coronary events. But perhaps the most important measure was this PBR 525, which is called the perfused boundary region. They could actually measure the glycocalyx, and the more it was damaged, the more likely it was that these people would then develop coronary artery disease over the next 6 years. And again, completely independent of the cholesterol levels. So as I bring this to a close, I want to point out, I just published some papers with some outstanding co-authors here, Blair O'Neill, a cardiologist, and Jeff Volek, who's very well known to this group, outstanding researcher in low carb diet. And when you look at the biomarkers that really matter, such as large buoyant LDL dramatically increases on low carb diet, and all these other markers, when they're going down, is improved, such as glucose and insulin and triglycerides, all improve compared to the low fat diet. And the small dense LDL right here declines significantly on the low carb diet. So we reviewed this in this paper we published 5 years ago, the great superiority of low carb diet to the low fat diet, and a very small overall change in LDL-C, which again, I would say is largely irrelevant. More recently, I had the pleasure to work with one of your own, Dr. Paul Mason, and Dr. Ben Bickman, wonderful co-authors in which we have this challenging title that statin therapy is not warranted for a person on low carb diet. And so I've kind of moved rather quickly through this talk, but the topics I've covered are in this paper. The conclusion being that LDL-C is largely useless because it is a hybrid marker of important as well as unimportant components. The low carb or the ketogenic diet improves all primary risk factors for cardiovascular disease. It is clearly irrelevant as to what effect the low carb diet has on LDL-C. Frankly, I would state that there is no evidence-based reason why the lean mass hyperresponders, these are the people that can have cholesterol that goes up to 500 as a result of being on low carb, or anyone else that is metabolically healthy should use medication to target, reduce their LDL-C. Now, what about the metabolically unhealthy person? Well, I would suggest 3 choices. You can go on a statin, which may very well have benefits, but you have to accept that there are significant and common adverse effects of the statins. A far superior choice, I would suggest, is to become metabolically healthy with the diet and lifestyle changes. Or to consider is that anticoagulant medications or antiplatelet medications are likely to be just as beneficial as statins, because that's probably why statins can work for a metabolically unhealthy person. So the alternative then is to use anticoagulant medications to improve your cardiovascular risk. There are just so many people that I've stood on their shoulders to be able to learn about heart disease and improve my risk for developing heart disease. I've got chapters in these books, and I highly recommend the book Ketogenic Diet, which just came out. And I've got a chapter in there on cardiovascular disease, which I co-wrote, in fact, was written to a great extent by Dr. Nadir Ali. So I highly recommend the chapters in these books and these individuals, all of whom I thank for helping me to get to this point, to be able to share what I've learned about cholesterol and heart disease risk. So I am on Twitter or X quite often. My username is LDL Skeptic.